Key Leadership Challenges in Addressing Workplace Violence is our episode topic. My guest is my friend and mentor, Dr. Patricia Kunz Howard, a PhD prepared nurse and Enterprise Director of Emergency Services at the University of Kentucky Healthcare. Patty was both the 2005 and 2019 president of the Emergency Nurses Association. She is also currently provost of ENA University, a fellow in the American Academy of Nursing, as well as a fellow in and the 2024 chairperson of the Academy of Emergency Nursing. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Patty, thank you so much for joining us today.
Oh, good morning. Thank you for asking me.
So this episode is a continuation of a series around the topics of both healthy work environments and then more specifically, workplace violence. Some of our previous episodes included Season 2, Episode 3, where we began touching the topic with Jeff Doucette. He discussed it within the context of nursing workforce engagement. I should note that Eric Martin also briefly mentioned workplace violence in Season 1, Episode 7. Our Season 2, Episode 6 topic with Bill Schuler was titled Addressing Workplace Violence. In Season 2, Episode 18, Becky Harris then examined it more specifically from a policy perspective. That episode was about addressing verbal aggression to reduce workplace violence. And in Season 2, Episode 21, Matthew Howard examined the somewhat related topic of bullying in the workplace and solutions for nursing practice. But today we're here to focus on some challenges from a leadership perspective. Just for some level setting, can you tell us a little bit about your organization, how long you've been with UK Healthcare, and how long you've been in your current role?
UK Healthcare is a quaternary referral center. We have about 1,000 beds between our two locations. We have a main academic campus, which has an adult and pediatric emergency department. And then literally a mile down the road, we bought UK Good Samaritan in 2007. And because we needed the beds, and this is a CON state, and there's a small community emergency department there. I've been back at UK Healthcare for 23 years, and I've been in my current role about 10.
In 2021, the Joint Commission came out with some new standards regarding workplace violence. What does the workplace violence prevention program look like at UK Healthcare?
It's one of the things I'm really proud of, the work that we've done there. I co-lead a strategic workplace violence prevention team at UK Healthcare that is interprofessional. It started as part of the nursing strategic plan, and we said this is not just a nursing issue. This is an all disciplines and professionals. It's EVS, it is dietary, it's the providers, it's the nurses, it's PT, it's OT, it's everyone who comes into contact with patients and families are exposed to workplace violence at times. And so we took it from that nursing strategic plan to an enterprise-wide plan. And so my co-lead is actually one of the administrative operations leaders, and her background is actually clinically radiology, but she oversees some of the core teams.
What are the expectations that exist for all leaders at UK Healthcare as it relates to workplace violence?
We have a zero tolerance for workplace violence. Another is that we are supportive of our staff and complete a post-assault huddle for every assault so that we can determine if there were things that could have been done differently to make sure the staff has the support that they need and to put procedures in place to avoid it from happening again. And then I think one of our really big strengths at UK Healthcare is we have behavioral expectations that are reviewed with every patient on admission. And if we have problems with their behavior, we actually have them sign a behavioral contract. And if we continue to have problems, that can be administratively discharged. And so we really, truly stick to our zero tolerance policy because we want everyone to feel safe at work.
Can you talk more about those behavioral expectations that are reviewed and what that process looks like?
So the behavioral expectations is literally a full page, and they are I will and I am statements that I will abide by the guidelines that are presented to me. I will not be rude, disrespectful. I will not do things that could cause harm verbally or physically. They're very structured. Legal was involved in the development of them. And it's very clear that, as much as it says what the patient will do, it also says that the staff will likewise treat them respectfully, be mindful of their care plan, communicate their plan of care. So it's a very clear document. And then if we have problems with them violating that behavioral expectations, as I said, we actually have a behavioral contract that stipulates these things have to occur or there will be further consequences. And we've been really successful with that program.
When did you implement that?
We implemented those about 2021, as a matter of fact. We were working on those before the Joint Commission recommendation came out, just because we felt like it was needed. We've had a pretty strong stance toward workplace violence for some time. As you may recall, back in 2017, when I decided I would run for ENA president again, part of that platform was workplace violence prevention.
Yeah.
And so I have a longstanding history of being very in tune to the need for people to feel safe in their workplace. And I'm fortunate to work in an organization that feels the same way.
And so you said you've been successful since you implemented it, about 2 years. What type of outcomes has generated from the implementation of this?
So our culture of safety score on our employee engagement has been good, which is really big, I think, when you look at a nationally standardized engagement survey from Press Ganey and you look at your culture of safety score and it's almost 4 at an enterprise that's as large as ours. That's really, I think, pretty remarkable.
Yeah.
And I think when you talk to staff anecdotally, they will tell you they feel like they have the support. They know that patients' behaviors won't be tolerated, and they understand their role in reporting. We still don't have 100% reporting because there's still those staff that are like they didn't know what they were doing. And yes, I understand that clinically there are times that patients do not know what they're doing, but still you have to document those events. It doesn't mean you have to press charges for sure, but you do have to document those events so we understand the magnitude and the incidence of the events, because while the patient may not have meant to hit you because they were encephalopathic, you still got hit. You still had to be seen because you have a broken jaw. All of those consequences still occur, and so you still have to support the staff regardless of the reason that they were assaulted.
I want to focus in more on these behavioral standards. How does that work? For inpatient or obs patients, clearly at the time that you're admitted or whatnot, it's reviewed. When you are placed in observation or when you're admitted as an inpatient, I would understand that kind of makes logical sense, as well as like for scheduled surgical tests. But translating that out a little bit further, how does that work for areas where there's outpatient diagnostic testing, or in the clinic where you've got outpatient visits that are occurring, or in the emergency department for that matter? When are those things reviewed, and who is doing the review of those things?
What is supposed to happen is that at registration, they are supposed to receive a copy of them. Then they should be reviewed by their care provider, whether that be a nurse, whether that be an MHA in the clinic, depending upon where they are. I'm not going to tell you that happens 100% of the time because, I know it doesn't. It's supposed to, but we all know there's a lot of things that are supposed to happen. Nurses are pretty good about it. I will say they're not 100%, but they're pretty good about it because they know that it is their way to make sure people are aware. Plus, we have 0 tolerance signs posted in every single elevator at UK Healthcare around workplace violence. And we have many other ways that we communicate to patients that there is 0 tolerance and that behavioral expectations will be enforced.
What are your expectations in the emergency department? What does that look like?
Same.
They're the same? Okay.
Absolutely.
You've used the word 0 tolerance a couple of times. And when we were talking with Bill Schuler, which is really about a year ago now, he explored the concept from 0 tolerance and actually was advocating to get away from that because of like encephalopathic patient that you described earlier, that in a scenario like that, 0 tolerance would be you're pressing charges on everyone, whereas a more balanced approach would be understanding the situation where things occur. What are your thoughts about that, of the use of the word 0 tolerance, and what does that mean at UK Healthcare?
So I think that's a really good point. For us, realistically, it means that really it's about intentional workplace violence, obviously. It's about those patients that are rude and nasty and that throw a urinal at you and those types of things. When we talk about 0 tolerance, we're really talking about intentional behavior. We understand that there are clinical things that you can't manage. The encephalopathic patient doesn't know. The patient that has dementia. I could go on and on about clinical conditions where the patient really doesn't know what they're doing. But realistically, it's around those intentional acts of violence is really what the zero tolerance is about, because that's what you can control, right? I can't control somebody that's not alert and appropriate and responsible for their own actions.
You talked earlier about the task force or committee that you're co-chairing. Do you have any other specific responsibilities regarding workplace violence?
We were the group that decided what de-escalation protocols and training would look like for the enterprise. And we decided that all 15,000 people at UK Healthcare would do Prevention First, which is a CPI course. There were some people that were unhappy about that because if they were a secretary in some place that didn't have a clinical responsibility, they felt like they shouldn't have to do it. But they can encounter a patient in the hall that's acting poorly, and they need to have the same training. If you read both the Joint Commission language and the recent CMS memorandum from November, it's very clear. Everybody that comes in your building that's there regularly, some vendors that are in there all the time, like the reps in surgery that are there 2 days a week, all the students that come to UK Healthcare, our volunteers, all of those personnel do Prevention First at UK's cost, obviously. We pay for that. And we have a very good partnership with CPI because that is our foundational course. And so areas like the emergency department, we obviously do a much more stringent crisis prevention institute training and we have for years, honestly, for as long as I've been at UK Healthcare, we've done that. Our security team does the advanced prevention of physical violence course, or what we affectionately refer to as level 4, because they basically have 4 different levels of courses. Our phlebotomists, we don't really have a lot of phlebotomists in the hospital, but our phlebotomists in the clinic, they've had some difficulty with patients there. And so they're going to do that level that is just beyond crisis, the Prevention First. They're going to do the verbal de-escalation training because they feel like they need that. So leaders' responsibilities, once we said we're going to do this contract with CPI, each area, we had to work with every area of the hospital and the enterprise to say, what level of training does your staff need? Because we have to plan for instructors. Obviously, Prevention First is all online. It's about 75 minutes. And it made some people really unhappy that they had to do a 75-minute online training, but it was not a question. It was 100% expectation. And I'm excited to say we met that requirement by June 30th. So I was very pleased. Incoming students this year, you can't get credentialed to come in our doors if your Prevention First is not completed. So that was one of our responsibilities. We've also we work on anything related to workplace violence. There was some concerns about our violence flag and EPIC and how it got there and if it could be removed. And so our group worked with EPIC about that we could put in some explanation behind the scene about why that was there. We've also made recommendations about how we manage entry into the facility, and we have had a lot to do with metal detectors. We're getting ready to pilot metal detectors for all of UK Good Samaritan. We're starting with that smaller facility because it's going to be easier to see what are the challenges we face there than doing it at Chandler, which is the big academic facility that has so many entrances because we have 3 different iterations of a building over time. And it's really challenging, although we do lock it down pretty well at night. But we've had metal detectors in the emergency department for about 15 months, and we've probably wanded for maybe 18 months before that, just wanded people. But now all patients and visitors come through that are ambulatory that come through the front doors, go through a metal detector. We still haven't worked out that ambulance piece because we haven't found a system to scan somebody on an ambulance without the stretcher itself making the metal detector go off. So we're still working through that piece. But we can have those patients wanded once they've been transferred to our stretcher without any difficulty if we have a concern.
What are the key leadership challenges that you've experienced in addressing workplace violence, both from a historical perspective and then also currently?
I think it still is an opportunity getting police to actually help with pressing charges. And I say that and want to go back and qualify that because we have a great relationship with UK Police. They've been fabulous partners. We have UK Police in our departments 24/7. They are wonderful partners and they have assisted us. We even have pre-stage barriers at Chandler because we've had some large crowd issues. And so we have pre-stage barriers so that if we get these large crowd issues that we can manage that to secure the perimeter and allow people to come and go as needed if we're not on full lockdown. But I think that certainly can be a challenge in and of itself because if they don't see it, they won't always press the charges. And so that I think is challenging. And that's not unusual, apparently. If you want to come to their office, they'll press them. But if they're present, they'll press them. And honestly, it arrests some of them and take them away, particularly out of the emergency department.
What are the specific laws that exist in Kentucky, if any, around assaulting healthcare providers?
There is a law, but it's not a great law. We also have a law that goes really the actual pieces of it go into effect January 1st, which is around de-escalation training and how you report and all of those pieces. And in fact, our reporting goes all the way to our board of trustees now around our incidences of workplace violence. We think we're really transparent with the work we're doing. And we want everybody to understand that it's important to us because, like I said, it goes all the way to the university board of trustees in terms of the incidences we see of workplace violence.
Circling back a little bit, you were talking about the reporting issue and the relationship with the police. Are there any other leadership challenges you've experienced with workplace violence, both historically and or currently?
I think historically we have had difficulty with buying with reporting, and we had some difficulty initially getting people on board to do post-assault huddles because they didn't really understand the importance of it. But they've seen the difference it's made and the responses that they've gotten from the people who actually did need support that they'd never realized before needed support. So I think that's been important too, and really has been an eye-opener for many areas. And otherwise, I've been pretty fortunate. I work at an enterprise or an institution that really is very supportive of a safe environment. So I think that's really a blessing, honestly.
If I'm an executive nurse leader listening to this podcast episode right now, what key things should I be walking away with and applying in my practice to prevent and reduce workplace violence incidents?
I think first and foremost is you should have behavioral expectations. That comes from leaders. I think that you also need to make sure you have a mechanism to support your staff. And I think you need to encourage reporting because that remains a challenge. Yes, our numbers are going up and every month they go up and are we having more and more events? We really are not having more and more events except in a few isolated situations where we've had some specific circumstances happen. We expanded our inpatient pediatric behavioral health beds. And so we've seen some more outbursts there just because adolescent populations and some of those things. Those numbers went up, but the volume went up. So it correlates if you understand what I'm saying.
What do you see as leading practices for organizations in addressing workplace violence?
Leading practices is really about doing the things you can do to keep your staff safe, having very clear policies about reporting, having very clear policies around support, having honestly physical things in place. People don't like metal detectors, but they're important. In the first 3 months that we had and wanding, even in the first 3 months we had wanding, we took off over 1,000 weapons off of people in 3 months, over 1,000 weapons. We have an ongoing report that we get. The most recent report was for, I want to say, the previous 3 months, and there were 49 guns and over 1,000 knives. And we have signs that say security screening ahead, weapons not allowed. All that signage is there, and people still come in the building with things that get taken away. So I think that's really important. I understand that there is a cost related to metal detectors because people have to be there to actually man those metal detectors and to do something about the weapons that are found. But what's more important than the safety of your staff, your patients, and your visitors? There's not anything that's more important than that. You have to view staff safety the same way you view clinical patient safety. It's important, it's essential, and it should be expected.
The access points, you said patients and visitors. Are staff required to go through the metal detectors, or do they have their own bypass routes that they can do with badge entry?
At Good Samaritan, that's part of the pilot. Everybody that comes in the building will go through a metal detector. And that is going to be very interesting to see how that impacts throughput to people getting into work on time. They have a different kind of a metal detector than what we use for the patients. And I think my analogy that I would make is it's like what you go through when you go into a concert, how you can hold your keys up above your head.
Yeah,
and your
those like
phone.
little thing, the walk-bys, so to speak. Yeah.
Yeah. I think that's what it'll be, but I haven't seen that yet. And it literally is getting ready to go live. So I'll be very interested. I think one of the biggest leadership challenges there is going to be to get people to go the way they're supposed to get into the building, which they really limited the access points. But ED staff in particular are really bad about going into the ambulance entrance. And so we'll have to break that behavior.
Any closing thoughts as we wrap up this episode?
Thank you for giving attention to this issue. It's really critical. This probably keeps me awake more at night than staffing because I don't like to think about people feeling unsafe. We had a very significant incident at UK Healthcare a couple of years ago where we made the national news because of an event in our parking lot with an IED or two. Not the thing you want to make the news with. And I just think I never want to see staff be that scared again, because they were really scared because of the events occurring out front. And we had to obviously move everybody away and back and out. And I said to them, I hope I would never knowingly let you be in danger. We are in a safe zone. I have been insured. We're in a safe zone. I don't want people to ever feel unsafe at work.
We learned a lot in today's episode today. The need for zero tolerance for workplace violence and having that in place in your institution. The need for behavioral expectations for patients and visitors. That's an essential practice. And the need for staff to be supported by their leaders with authentic leadership. Patty Howard, thank you so much. I really appreciate your time today, talking all things addressing workplace violence.
Thank you, Nick. Have a great day.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.